Okay, Dr. Rice, if you want to get going, it is all yours. We're going to have Dr. Rice start, and then at the end, we can ask some questions, and then we'll kind of shift into our case study portion.
Okay, so I'm going to talk about CVI diagnosis and medical testing, just so that you're aware of the process that we go through as eye care providers to make the diagnosis. Um, this is I'm presenting on the behalf of both of us. I'm Melissa Rice, we met last time, and Dr. Terry Schwartz is our founder of the CVI and low vision clinics at Cincinnati Children's. And she's been a leader in the field of CVI and low vision. And she lectures nationally and we do research together as a team as well. Let's see here. And so our objectives by the end of the session today is to be able to describe the medical diagnosis process for children at risk for CVI and identify pathways of referral for those demonstrating red flags. And it's really just to make you more familiar with what we do on our end so you feel more comfortable talking to families as well. So, whoops. Sorry, I'm getting used to doing it with my mouse here. And so let's see here. So CVI diagnosis testing, we do a focused medical history. Some of this we've talked about last time as well. The visual behavior history, we utilize the screening questionnaires that we talked about last time, and the assessment of visual function and eye exam. So as you remember from last time, the focused medical history, we want to find out what their medical history is significant for. Were they born prematurely? And if so, did they have complications at birth? Do they have the diagnosis of PVL? Um, did they have a hypoxic event or low oxygen? A stroke, brain infection, hydrocephalus, brain injury, not including non-accidental trauma or trauma in general, seizures, especially infantile spasms, or did they need a hemispherectomy? Drug exposure during pregnancy, what were they exposed to? Was it multiple or, or just one? And genetic conditions and brain malformation. So that's kind of just a higher level overview from last week. The visual behaviors we talked about last time, variable visual attention. We watch for these within clinic. Do they use touch to supplement the vision? Do they look away while reaching if they're reaching for your toys? Do they seem to need us to come a very close distance to them? I mean, we work pretty close anyway, but are we having to bring things abnormally close for them to see things? Is there certain colors? Do they have a harder time with your small puppets versus do they need something lit with the lights low? Are they light gazing or do they appear to have light sensitivity? Is there a slow response to visual stimuli as you're working with them? Do they seem not to respond unless you give them time? And these are things we can ask the families too. There's definitely certain things I ask if they have trouble with clutter versus if things are simplified. Is there a preference for familiar versus new objects? And do they just seem not curious visually? I keep wanting to turn the slides with my arrows. Screening for CVI, the purpose of it is to identify children at risk for CVI, to suggest a referral for a diagnostic exam. Sometimes we have a hard time, even Terry and myself, diagnosing them within a typical eye exam, and then we refer them to our diagnostic clinic, where we can spend more time and we can spend time with our colleagues, the TVI and the occupational therapists that specialize in CVI, and together we can make that diagnosis. Define the impact on visual impairment. That's another goal, is daily life activities, education, safe travel, and socially. So the visual function, we're going to look at, what we do in an eye exam, which is visual acuity, eye movements and alignment. And I would say this is an eye exam plus because it's focused for CVI. Contrast sensitivity, color vision, and accommodation, visual field, refraction, and ocular health. And you see the blue circle there. That is highlighting the anterior segment, the optic nerves and the optic nerve pathways in those pieces of the puzzle, not necessarily the perception, but there will be a few tests of that included. So our visual acuity, what we really like to do is get a measurable, a quantifiable visual acuity. And for our children that are nonverbal and have cognitive delays as well, teller acuities can be very beneficial because it's a forced choice preferential. So one side of the card you can see here, this is an older prototype where it has the stripes and the circle. It's actually more to the right, the grading targets here, where it has black and white targets, and it gets to the point where it's hardly detectable to see. Like I have a hard time seeing it. And so what it does is if you have a child that you're checking the vision, if they can see it, they're going to see those high contrast black and white, and they're going to be drawn to look towards that because it's a visual stimulus. If they cannot see it, or if they're just completely uninterested or don't have the level of vision to be able to see it, they're going to not look anywhere. You know, and there won't be a purposeful gaze, but it's very obvious when there is. And so this is detection acuity. It's not recognition acuity like Snellen visual acuity chart, but it does give Snellen approximates, and it gives you a level of vision, which is really nice for the educators and other providers. So this is one we utilize in our young population that are able to match. It's Leah symbols, and you see the card here where there's a circle, a square, not a triangle, sorry. They often call it a triangle. It's a house. And then the apple is often called a heart, and sometimes it's called a tooth. So we kind of go with whatever they say, as long as they're consistent. And there is low vision charts that we use in our low vision clinic. We have them on our visual acuity screens, which are M&S testers, or and then private practices might have them too on their screens as well. And we often present single targets with little lines around them, and that creates the effect of an entire line. Like when you get your eyes checked and they have a full line, like 20/20's TZV ECL. You have the full line, and if you have the crowded symbols around it of the shape, the visual pathway interprets that as a full line. So it's hard to do and hard to get it small if you have any decreased vision. And single letters are easier. But the one in the middle is playing cards, and sometimes we'll do that where we'll have them match, which can be fun. And we can get a lot out of kids that way. And then over to the right, that's a near visual acuity test. And so we can test the near visual acuity, and the little string in there has it set for 40 centimeters. Oops, I went too fast. The visual acuity is about 2,600 at birth. And this diagram up here in blue is the teller visual acuity cards, and those in the norms. There's been so many studies that have found the norms. So that's cycles per degree, because that's how the teller cards are rated. We always rate the Snellen on our report, as well as the cycles per degree, but the Snellen means more to most people. But we can tell if they're within normal for their corrected age. The other thing I think it's important to know is what to expect at different ages. This little, I think it's a rat, little picture that Terry has is between 2,400 and 20, actually, I can't quite see it. Oh, 2,600. And so it shows you the blur, you know, what they would see. But around age 3, it's between 2040 and 2050, depending on what guidelines you see. And I always say by 3.5, if a kid is on it, you know, they should score closer to 2040. But at the younger age, 2050 is typically fine, as long as everything else looks good. And then for age 4, it's between 2030 and 2040. And then by age 5, at least if you screen kids that are just entering kindergarten, they're not very comfortable with letters or shapes. then they might score a little worse. But by 5.5 or so, or once they've gotten into kindergarten, usually 2025 is pretty solid. So those are what you would expect at those ages. This is based on a paper. It's a nonverbal. If you have kids with limited visual response, to be able to document something. And these are kids with CVI. Direct visual acuity signs, like can they localize an object? Might be a large object, might be bright or lit objects, but they can. Can they move their head or their limb? Because some are spastic quadriplegic and can't move their limbs. But do they look towards that object? And then eye movement, where they actually make purposeful looks if you have objects out for them to track. And then there's indirect signs. And I think those of you that have worked with kids with CVI will recognize these, where they just change their posture. They want to get away from you. You're asking too much. The room's bright. There's a lot of clutter. They just shut down. There's a lot of avoidance, change in breathing. Sometimes they just smile at you and don't look until you really warm them up and modify the environment where they start to look. So there's other signs of response. We don't need a visual cortex, which is the back, right? We don't need that just to respond, a pupil response to light. Or blink to light, but we do for blink to threat. So by 2, this isn't present at birth, but between 2 and 5 months of age, it's a learned response that requires visual attention. So they should blink to threat. And if it's not present, the CVI is really severe. So contrast sensitivity is another important measure. It's the ability to distinguish between similar shades and distinguish objects from their background. I always say the grays in the middle of black and white to explain it to families. But you can see these pictures here. It should be adult-like by about 7 months of age, and it can cause difficulty with safe travel, social interactions, and reading. And this woman here, you can see how in the high contrast image where you can see it distinctly, she's kind of snarling at us, right? But if you look at the low contrast, if a kid has low contrast, they might think she's smiling, that she's happy to see them, because they can't really, it's hard for them to really distinguish the nuance of facial expressions. Where on this one, she doesn't really look pleased. And then, so it's important for those social interactions and reading facial expressions. And some of us don't have high contrast faces, between the hair and, if you don't wear a lot of lipstick or have bold glasses, it might be hard to see those details. These are some of our tests. We really use the Hiding Heidi, which is the top one there with the face, because it's another forced choice test. And you can measure different levels of contrast sensitivity. Pelly Robinson is on this lower, I think you guys can see my pointer. It's the VRS one. And then the Leah symbols come in like low vision charts that you test at 1 meter. And that has the shapes and the numbers. And so that is utilized as well. This is just looking at eye alignment. This is something us eye doctors do. We use cover testing, which is, the little cover petal there. All our cover petals are black. I don't know why this is white. I just took the image. But we look to see, does the eye move when we cover one eye? And then if you alternate, how big is the amount of the deviation? Hirschberg is when we use a flashlight towards the bridge of their nose and it shines on their pupils. And you have to have it right underneath the eye that you're pointing to the bridge of their nose and it's under one of my eyes, right? Because of parallax. And so I look to see, is it evenly spaced? Or if their eye is turning, you will see a discrepancy. And then Krinsky is just using a prism that we use to measure the amount that's using Hirschberg. And that's really detailed, sorry. But I figured since that might be in the reports, it's kind of nice to at least have an overview. So why we're doing that cover test or different tests like Hirschberg and Kremski is to see, do they have strabismus? Is one eye preferred over the other? These pictures here, the top one shows an esotropia. So if you look at this little person up top with the dark eyes, it looks like their left eye is turning in. And that actually is a good example of a Hirschberg, right? So you can see the pupil, it's hard to discern the pupil versus the colored part, the iris, but the pupil, it's pretty centered there, right? And then in the left eye, when we're looking at it, so our right, his left is, it's outward towards the edge. So that means the eye is turning in. Exotropia is when the eye, that patient's eye in the next picture is going outward, and you can see that eye very deviated. That's a large drift. Hypertropia and hypotropia aren't as commonly seen, just usually they're really mild and they're only seen on our exams, but this is a really dramatic one. I just thought it'd be good to show. The left hypertropia, and then there's a picture on that blue-eyed person. They have a left hypotropia or downward drift. So one thing we really find important for kids with CVI is looking at ocular motility. Can they keep fixation steady? Can they stare? Can they hold fixation for longer than 3 seconds? Because, you know, visual inattention is one of the key markers. And so normal fixation should last longer than 3 seconds. And the number of kids that don't are pretty high in our group of more significant CVI. Smooth pursuits are the slow eye movements we use to track something. So if you're looking at a car or bicycle go by, it's the slow eye movements. So we usually use toys to evaluate that. And are they able to keep fixation, or do they kind of lose fixation or have little flicks of their eyes? Not nystagmus, not the jiggle, you know, but they're just not able to just track it smoothly. That's common with children with CVI. Saccades or the quick eye movements. We use those a lot when we read, you know, we're jumping between words. And with sports and other things, but can they move their eyes between 2 targets? If they can move and accurately, a lot of times kids with CVI will be able to fixate on a target. Maybe they can go to another target if they're high enough functioning with if they're able to go between 2 targets. But a lot of times they'll be they'll miss the target. They'll go a little under and have to make up one. So they're not usually accurate. Okay, so we typically by 2 months of age, especially 5 months of age. So infants by 6 months should be able to fixate a target. And their saccades, their quick eye movements, should be pretty developed by 4 months of age. And then the slow eye movements aren't really good until they're at least 8 weeks old. So I guess you could one could assume that by 6 months, the ability to track between 2 targets, fixate, and use smooth movements should be pretty accurate. There are problems associated with movement. One is like if they have a palsy of the eye. So their eye drifts outward, and then you try to get them to track, and that eye will not go anywhere. Even if you cover the eye, that's better. That means there's some kind of neurological palsy of that muscle, and there are certain ones that happen. Ocular motor apraxia. These babies sometimes look kind of blind. They have a difficulty going between, like making voluntary saccades. So you bring up a little Elmo toy and a little, you know, I don't know, a little Cookie Monster, and they can't really go between the two. But they whip their head, you know, between the two to make their eyes go. And then this is something they're born with, and we don't know exactly why. The etiology is unknown. Sometimes the MRI will have findings, sometimes it'll be like completely normal, and it can be associated with other neurological findings, but often it'll just improve over time, you know, and so it's just kind of one of those ones that is a little tricky. So just be aware of that it's out there. Accommodation is the focusing muscles. And so we have the ability to focus our eyes up close when we're young and healthy, right? That changes typically after late 30s, early 40s, but prior to that, in our pediatric population, they should be able to focus up close. That's fully developed by 4 months of age. And something to note is that kids with poor vision, including those with CVI, will hold things really close, which makes everything bigger. But it's kind of paradoxical because it makes things bigger, but it also makes them work harder. So that's one thing we like to evaluate, is to make sure they can focus well and they can sustain that near point. So here are a couple of tests we use. Near point of accommodations, where you use a small target. You do one eye at a time, and you see how close they can get to their eye, and there's age appropriate norms. And then dynamic retinoscopy, or MEM, like I got a monocular estimation method, is where you have them look at, sometimes we use movies, Miss Rachel, something that they'll attend to in clinic. And so something ideally with detail, but you have to work with what you can with the CVI kids. And you make sure that they're actually looking at it. And then we use our retinoscope to look at the reflex to see if they're focusing right on that target. So there are a couple groups that frequently have troubles with accommodation. So children with CP, about 50 to 60% have an accommodative lag, so an under focus. And the way I explain this to families is, if there's other muscle issues, this is a muscle, it's a neural, it's a loop, and sometimes this can have trouble dialing it in. And then what we do as eye doctors is we factor that in their prescription. Sometimes a bifocal works great, and sometimes with mobility issues, a bifocal is terrible. And so if they're in a wheelchair and not self-mobilizing, we will sometimes correct or give them a little more plus in their prescription if their world is more up close, to give them that magnification they need and decrease workload. The other population where it's very common is trisomy 21 or Down syndrome. And these are small studies. There's bigger studies that need to happen, but they, on every child with trisomy 21, I always check accommodation because it's really frequently under accommodate. And there are groups in England that automatically put them in this population in full plus with a bifocal, and really feel that works best. So just something to keep in mind. Color vision is something we test when able. We have down here, you'll see the D16. We have large versions of these color chips we can use. Often we'll use this plate over here to the left called the HRR plates, because you have a circle at X marks the spot and a piece of pizza, like a triangle. And a lot of our kids can do it. So whenever we can measure color vision, we do. There's definitely an early preference in all children's lives for high contrast primary colors. Red is the most primitive. So if we have a child with CVI that prefers red, it's definitely a more severe CVI. And then if they prefer blue and green, I mean, they're more further along, like developed as far as visual ability. So we also like to measure the visual field to see if there's any visual field limitations, because that's going to change how you present things. And it's fully developed by a year of age. If they're sucking on a pacifier, it will make their visual field from being full to constricted. So don't let them do that when that's getting measured. And sometimes the field can recover. So if you see damage on the MRI, that should point to a visual field restriction or constriction. Sometimes things can recover. Kids are pretty amazing that way. So one way we do it, this is an arc perimeter here in this photo with a baby, and they're having it stare at this white ball. And then we do this in our clinic quite a bit if we can maneuver it, if the visual attention is enough to do it, as we all have two people are involved in this, and we have a visually engaging target to the level of what the child needs in the front, and then we bring a target from the periphery and try to get the degrees. So it's more like what you've done at the eye doctor, where they hit the little dots, the little trigger, and get a formal visual field. If we are unable to use this, we'll just do a two-person visual field and have the target come from behind them and try to get what their functional field is. A few tests of visual perception. Dorsal stream is the mailbox test, and the Leah rectangles. These are both made by Leah Harvanen. I said it wrong. And then the ventral stream is like facial expressions test, and they can do it by matching, by naming. The Leah rectangles down here, they match the gray to the black, and then we also have them line it up, and it's just kind of to see if where they get confused, if they get confused. The mailbox test is presented vertically, horizontally, and diagonally, and they have to go through a slot so you can look at that dorsal stream. Are they able to direct their movement of their arm? Oops. We always, this is required for our team visits, this is required prior to seeing us, but for our regular exam visits, we always check refractive error. Cycloplegic retinoscopy is the gold standard for this population, and that is dilated with 1% tropicamide. And if they're older children and capable, we might manifest refract like we do with adults. But it's important to know their baseline refractive error. So if we find they need like reading, like we find under focusing, I can factor that in. So if they're like a -6, say they're very nearsighted because they were born prematurely, that's a higher risk for myopia. They're very nearsighted, -6. But we find that there's an under focus of like 2 or 3 units. We're going to go simple. Say it's 2. So then I'll prescribe, instead of the -6, I'll prescribe a -4. If, you know, there's a level of CVI where they're not looking at the chalkboard, you know, at the school. They're needing to be able to see in that 4 feet range or 3 feet range or closer. And that can improve visual attention and visual fixation and just their ability to sustain it. We always look at the health of the eyes. Dilated eye exam, this shows the headset we use, the BIO, binocular indirect ophthalmoscope, or flashlight hats, what I call it for the kids. And then we use a lens that helps us focus that light because the eyeball is small and into the back of the eye. And then we look at the optic nerve health and just the retinal tissue period to rule out any other pathology that could cause decreased vision. This is a fun diagram from Gordon Dutton that has down here at the bottom has the visual scene, the right and left eye, and it has the parts, you know, like the retina, optic nerves, chiasm, and then it has your reflex vision from the superior colliculi. It has all the things it goes through, and then it branches out for the dorsal stream going to the posterior parietal lobes. I just think it's a good diagram. Ventral stream to the temporal lobes and kind of breaking it down. And I wanted to include it for you to have. So if there are concerns, for those that are out, not here at Children's area or Cincinnati in particular, we recommend messaging a child's doctor, you know, reaching out to their primary care, the person who referred to you, could be neurologists, peds rehab specialists, to let them know you're seeing abnormal visual behavior during your evaluation and that you have concerns that the child might have CVI or characteristics of CVI. And if that person needs to be the one referring to a pediatric eye doctor for further evaluation, then you can, you know, keep them in the loop and let them know you're seeing some things that are suspicious. And I think that is always good, especially, you know, with the PCP, keeping them in the loop or whoever that primary person is that they see. And referring to a pediatric eye doctor with suspicion of CVI, you know, and that gives that doctor a heads up, like I need to look for these things. We also have our low vision team. We have our CVI clinic, which you guys know about. We have a dedicated phone number for our point person for scheduling, so it's included here. And the other thing too, if you're connected with early intervention, to let your team know that you're seeing some vision things so you can add that piece if it can be added, and things like that. And you can, the one thing I was looking into for Help Me Grow, and I think there are several of you on here that are experts in this, is I think you can refer, like anyone can refer to early intervention. So if you have a little one, I think that any of us providers can send a referral in, and that is one thing I forgot to add on again. So that is something else that I recommend. And then I think here's some that is just references. And then I think that's it.
Okay. Thanks for presenting that, Dr. Rice. I know it's a lot of somewhat complicated information, but I think you were able to kind of plug in some more simple ways for us to kind of get on your eye doctor level of understanding. Before we hop into questions, we have one question that came through the chat, which I think you kind of covered, but I think it could be a good thing to revisit was Janetta was wondering, how common is it for children diagnosed with CVI to be interested in looking at people's faces? So I know you mentioned some of that contrast sensitivity piece, but can you talk to like eye exam and more of that facial interaction specific with CVI?
Yeah, I think it depends by level. I know that there's some controversy on how you talk about level, but and I know that Elsie and Kelly will talk about CVI in more detail, but if the kids are staring at lights primarily, it's hard for them to look at faces. And that may or may not be due to reduced contrast sensitivity. A lot of times they do have reduced contrast sensitivity, the kids that are more and that have more severe CVI levels. And, some of that might be due to some concurrent, like some comorbid optic nerve pallor, like where we look at the nerve and it's pale because they had HIE or something like that. So that could be definitely reduced. And some of it's related to visual attention, right? Because we can only measure there's a subjective test. We can only measure what they'll respond to. And if they have trouble responding to visual information, then the testing is going to be poor. And I would say, as far as like, I don't have a percentage, but I know the more severe the CVI, the more issues with the facial typically recognition and expression, like the ability to see the contrast. And on the higher levels of CVI, there sometimes can be that, but it's less common.
Okay, I think we'll open it up for some more questions. If anybody has a question, you can raise your hand or put them in the chat. Anything regarding kind of that medical piece. Looks like Jeanette, you can go ahead and unmute if you had anything else to ask.
I do. I'm sorry for monopolizing the questions. I have two that are unrelated to each other. One is, how much auditory input do you provide during the evaluation? So spoken directions, for example. And then my second question is, for non-speaking patients with dysconjugate gaze, how do you determine which eye is the dominant eye, and what if the dominant eye changes? Thank you, Nadia.
Yeah, good questions. Well, a lot of things we do are independent of the kids. A lot of the evaluation, I do talk to the children just like I would for any child, whether I think they're understanding or not. I do engage and try to address them directly. If in other circumstances, like if, say, there's minimal visual response and I have to turn all the lights down and use light up toys that are silent, then I'll stop the conversation, because that's just adding to the complicated nature of things and making it more difficult for them to process. But I do kind of, for those situations, I do stop talking and engage them more silently so that they have time to visually process what I'm showing them. But I'd say, as a general rule, I kind of just explain what I'm doing because I will always assume that they understand what I'm talking about so that I'm not just a stranger in their face. But then I do finally stop talking. I feel like I'm just talking continuously right now. Stop talking and engage them visually without because that's just going to minimize their interactions. As far as the strabismus piece, so a lot of kids will have an alternate strabismus, especially with XT, outward drift. That if it's a large ankle, strabismus is much more prevalent in children with CP as well. And think about that as a motor issue as well. And I think it's about 50% of that population have strabismus. And so if they are able to hold straight sometimes and then drift out, I watch to see which eye tends to drift out more frequently. I also will ask the parents on their thoughts of it, but I record what I see as their preferred fixating eye, and I note the fixating eye, and then I also note which eye is drifting out or if it's alternating. The preference can change. If they have a disparity in visual acuity where one eye sees better than the other, it's usually the eye that sees better that is preferred fixation. But if they're pretty much equal or within one line, it can vary on which one. And I feel like I'm going through a rabbit hole. I'm not sure if I answer your question or if I need to refocus. Can you help me?
No, I think you're going in the right direction. The reason why I'm asking this, I did have a patient with dysconjugate gaze, and mom confirmed that his dominant eye would change from time to time. So it wasn't one of those like over time it switched over to the other eye, but it was literally by the day, and sometimes throughout the day it would change. So it was really challenging, and he was non-speaking. Mm-hmm. And using an eye gaze device. So it was very challenging to figure out, okay, how do we optimize this for him?
Mm-hmm. It definitely can be tricky. And it typically is the exotropes, the one that's drift outward, that are the trickier ones. But so yeah, I don't know how you can, because you can't force the visual system to pick one dominant if it's an alternating strabismus. If it becomes too cumbersome, I mean, one idea is like they could see a, pediatric ophthalmologist about potentially surgical correction if it's getting in the way. That's an idea, if their family was interested.
We had another question come in from Amanda asking if they're not located near Cincinnati, are all eye doctors trained to diagnose CVI, or should we look for a specialized doctor, or what type of doctor?
I would say if there's a pediatric optometrist or ophthalmologist, that's what I would recommend. Everyone should be trained in diagnosing CVI. However, the level of training is not a lot. We just published our study on that, and the average, not pediatric, ophthalmologist and optometrist get a couple hours, 1 to 2 hours during their training on CVI, which is a complex condition. So I have to say that our goal is to improve knowledge base among eye care providers so that they do feel more comfortable. And we've done a lot of lecturing, a lot of, education, but that is definitely a challenge. So if there's somebody within your area that is a pediatric optometrist or ophthalmologist, that would be best. If not, maybe an ophthalmologist, since they have, the medical training, the medical school background, and are more familiar with that. Not to be dismissive of my optometry colleagues, because there's some really great eye doctors out there, but that could be like your primary peds, OD or MD, secondary general ophthalmologist, and then your primary care optometrist, maybe as your hierarchy. Thankfully, in the state of Ohio, there is Ohio State College of Optometry, which a lot of people have trained, and they are very good. And there are people within that school that are very knowledgeable on CVI. So hopefully they've had the background.
Any other questions for Dr. Rice today? Raise your hand or put in the chat.